Hi guys, this is Dr. T and welcome to Clinical Medicine with Dr. T. So guys, this is part 3 of our series. It's the last part. So in this video we'll be discussing, just when I finish this topic, why do we advise patients not to take high salt diet when they are taking antihypertensives? So what are the effects of high salt diet on BP control, especially for hypertensive patients and heart failure patients? So we did say that, guys, the rest system is very important to understand. Very, very important to understand. So we did say that this system, just briefly, this system is mainly concerned about increasing BP. So it kicks in when there is hypotension. That's the rest system. So, and we said that the reason why the rest system kicks in when there is hypotension, it's to make sure that organs are well perfused. We don't get to a point where we have hypoperfusion and we get our organs being damaged because of hypoperfusion and have the patient demise because of that. So when you have hypotension, which is a low BP, this system will kick in. So it will kick in So this system will kick in to make sure that the blood pressure increases, the BP increases. So that's what the rest system does. And we know that the rest system increases blood pressure. We know now the pathway that aldosterone is the main driver of this. And we know that along the pathway, before aldosterone can be released, angiotensin 1 must be converted to angiotensin 2. We know the story. It's prorenin, then renin, cleaves angiotensinogen, then angiotensinogen converted to angiotensin 1, and then angiotensin 1 is converted to angiotensin 2. And we know that for us to move from angiotensin, for us to move from angiotensin angiotensin 1, we need to angiotensin 2, we need the enzyme, the ACE enzyme. So guys, please be with me here. So we know that aldosterone will exert its effects, causing the reabsorption of sodium, and then water will follow. And we know that when enough molecules of water have been reabsorbed, blood volume will increase. As we have been saying, blood volume will increase. And we know that BP is equals to cardiac output multiplied by peripheral resistance. So, and we know that cardiac output is stroke volume multiplied by heart rate. We also know that the factors that contribute to stroke volume is preload, contractility, and afterload. Right? Now, when you have said this before, the determinants of preload, one of them is venous return. Venous return, right? So Venous return depends on the amount of blood that is in the circulation, that is in the system, and that is blood volume. How much blood do you have there? So, which means that if you increase blood volume by absorbing a lot of water or drinking a lot of water, you will eventually increase preload, stroke volume, cardiac output, and increase your BP. This is what aldosterone does. It reabsorbs sodium, water follows. When water follows, gets back to the system, is reabsorbed back into the system, your blood volume will increase. This is how, and then now, after you have done this for some time, you start having an increased blood pressure. You get a normotensive patient. Once you get to normotension, this system is going to switch off. Homeostasis will make it to switch off when you move from hypotension to normotension. The system is going to switch off. Now guys, please appreciate this. This rest system, we have said it's concerned about increasing blood pressure. It does that by increasing reabsorption or stimulating reabsorption of water. Now, once you have a patient who has hypertension, a patient who has hypertension is a patient who has a chronically elevated blood pressure, because we all know that BP is equals to cardiac output multiplied by peripheral resistance. Now, you have a patient who's hypertensive. They chronically have an elevated blood pressure. That's what hypertension is. Now, if the rest system is activated in those patients, that hypertension will be worsened, because we know what the rest system does. The rest system eventually increases blood pressure. So if it's switched on those patients chronically, it will worsen the what? The hypertension. This is why one of the medications for treating hypertension, one of the class of drugs, is ACE inhibitors. ACE inhibitors, they block this enzyme from converting angiotensin 1 into angiotensin 2. Once you block this step, then you have switched off the rest system. You will allow, so there's going to be hypotension in this patient, let's say, but there's going to be the prorenin will be secreted, the renin will be secreted, and the angiotensinogen will also be secreted. But when they get to this step, the pathway is blocked. This is how you switch off the rest system, because you know that the rest system is not good for a hypertensive patient. It worsens the hypertension. Right? Point number 2. Talking about the CCF patient now. When you have a CCF patient, the same thing happens. The rest system is activated, and then now with CCF, what you have, you've got a chronic state of volume of fluid overload. Now, when you have fluid overload, you give a patient diuretics. You are giving a patient diuretics because you know that once you can sort of like make them to pee, they will feel better. Now this system is making sure that they are not they don't urinate. So that's why you also need to use ACE inhibitors for heart failure patients to to switch off this rest system, right? Now imagine giving a patient, like even for both cases, you give them diuretics, but you have got a system that is concerned about water reabsorption. That just wants patients to reabsorb water, reabsorb. And the more water they reabsorb, for hypertensive patient, they will increase their cardiac output and increase their blood pressure. So you won't win with your antihypertensives. That's where it is. So I'm going to say it again. The REST system is horrible for hypertensive patients. It's horrible for CCF patients because of these reasons. Right? So that's why we've got these ACE inhibitors to switch off that REST system. Unfortunately, with heart failure, remember, heart failure is a state whereby, or is a condition whereby there is the heart doesn't meet the metabolic demands of the organs. So which means there's a little bit of hypoperfusion of organs when it comes to CCF. So which means in CCF patients, because of the hypoperfusion that I'm talking about, the slight hypoperfusion that is there, which is chronic, the REST system is chronically activated in heart failure patients. That's why if you don't deal with the REST system, they don't get out of failure. So that's why you want to switch it off, right? Okay, guys, let me just clear space. Okay, guys. Now let's come to the question. Why do we tell patients to go to decrease their salt intake when they're hypertensive and when they've got heart failure? Okay. There has been a couple of studies that have been done around the world. This is the interesting thing. Aldosterone, as we all know, the effect it has on high blood pressure. So when it's secreted, now we all know, and it's coming from the REST system, we know that it causes reabsorption of sodium and reabsorption of water, and then the blood volume increases, and then subsequently the BP increases. Now it has been found that salt alone increases high blood pressure. Aldosterone release also alone increases high blood pressure, independent of salt, and also salt is able to increase high blood pressure independent of aldosterone. But it has also been found that these two, when they are together, the effects of high blood pressure, they are profound, they are exaggerated. Now, here's an interesting thing. The studies that I have read, they talk about, they call it the aldosterone salt interaction. They call it the aldosterone salt interaction. So in one particular study, what they did is that they took two groups of patients who had hypertension. One group was given a high salt diet, and then the other group no salt, and they were given antihypertensive, same dose and everything, same class of drugs and same dose. Now what was found, so they checked the aldosterone levels. So what was found is that patients that were on a high salt diet, they had high levels of aldosterone. They had high levels of aldosterone. And their blood pressures were forever high. They were always high. So they had high levels of aldosterone, these patients, compared to these ones. These ones had a lower level of aldosterone in their blood. This is when they concluded that a high salt intake does contribute to the increase of aldosterone. And remember, when you've got a high aldosterone, you're gonna get here. And we know that when you've got a high aldosterone, it's like when you've got a primary aldosteronism, where you have got a tumor that is just secreting a lot of aldosterone. Those blood pressures, they keep climbing and climbing and climbing, and you can be on 5 drugs, 6 drugs, then the blood pressures they just keep climbing. So you, up until you actually deal with it, with the aldosterone secreting tumor. Now that's primary aldosteronism. But in this case, that's primary aldosteronism. So, but in this case, you've got a situation whereby you've got a patient who's taking a lot of salt. Now they've got a high aldosterone in their blood. So in a way, you have created some kind of hyperaldosteronism, because now you've got high levels of aldosterone in the blood. And it was also discovered that once these patients went low on salt, their aldosterone also went down. Very interesting finding that these guys made. Very, very interesting. So this is the reason why we don't want patients to be on a high salt diet. Remember what we said. When you've got a lot of water in the blood, you increase blood volume, and then therefore you increase blood pressure. So we have explained that now. So this is the reason why, guys. This is one of the reasons. I'm sure there are other reasons as well, but this is one of the reasons. Yeah, I hope that's it. I think that's it. Thank you.